Good morning, everyone. We welcome you all to OrthoTVonline.com, and this is a session in association with Minimally Invasive Spine Surgeons of Associations of Bharath, and I hand over the meeting today to Dr. Amit Jhala, who's the convener.
Thank you, Neeraj. I welcome you all for this fifth meeting of MISSAB, and as this time we have the topic of full topic on endoscopic spine surgery, especially Destandau's technique, and we have a star-studded faculty of Dr. Srinivasan, Dr. P.C Dey, Dr. Mukul Kaushal, and all the panelists. I welcome them all to convene this meeting. And we have, as our routine, we have a journal club and a case presentation from our members also. So I will hand over this meeting to convene to Dr. P.C Dey, and I would request everyone to stick to the time because we have lots of things to be shown. And for the beginners who want to learn the Destandau technique, I think this is a feast for them to have all these faculties who are the pioneers, internationally pioneers in Destandau technique, to show from basics how it has to be taken by the beginners. And for thespians who have already, they will have these smaller intricacies which they will show in their video techniques. I will give mic to Dr. P.C Dey now to moderate the whole session. Dr. P.C Dey, please.
Thank you, Amit. Our today's the convener of the session. As you know, the endoscopic spine surgery has started replacing the conventional microdiscectomy in various centers across the globe. Surgeons are comfortable with the surgery during surgery, and also the more number of surgeons are into it nowadays. Publics are accepting, rather than demanding the technique. With development in the field of optics and the instrumentation, the field of endoscopic spine surgery evolved immensely. The indication not only to lumbar paramedian or the lumbar canal stenosis, rather it is a high-graded migrated disc, sequestrated disc, and sometimes the huge central disc, thoracic disc, cervical disc, also the lumbar, thoracic, and the cervical canal stenosis, even the multiple level stenosis. So good morning, friends. Today we are going to discuss how we chose the technique, which one is the best for us, for the beginner especially. The three things always comes to our mind when we thought about the endoscopic spine surgery. Which technique is best for the beginner, like UBE, Destandau, transforaminal, full endoscopic. The second question comes to our mind is the learning curve. And the third one is the unexpected complications. So today, we are very much hopeful that we will clarify our doubts in all these 3 points. Now, the first we will start with the journal club. I will invite Dr. Saurav Nanda to present his journal topics. Start with Saurav, unmute.
Good morning, everyone. Am I able?
Yes, you full screen.
Hello?
Do your full screen. Yes.
Yeah.
Go ahead. Go ahead.
Yeah, I am Dr. Saurav here. In the next 6 minutes, I am going to discuss the article Functional Outcome After Endoscopic Lumbar Discectomy by Destandau's Technique, a prospective study of 614 patients. This article was published in Asian Spine Journal in the month of October 2019. The primary investigator of this research was Dr. P.C Dey. At the end of the presentation, we can able to know how this endospine system works, the techniques, the instruments that we need to use, advantage and associated complications. We will also have the data of functional outcome of lumbar discectomy by using this system in a relatively larger population. Way back in 1993, Professor Jean Destandau introduced this novel system for endoscopic spine surgery, and it is an established method now for the treatment of disc herniation. The reason for its popularity is for its cosmetic small incision, minimal tissue disruption, enhanced visualization due to better magnification and illumination. The patients need to stay at the hospital for shorter duration and recover faster in comparison to open procedure. The aim and the objective of the study was to interpret the effectiveness of the lumbar discectomy procedure with Destandau's endospine system by evaluating the functional outcome and complications rate. This was a prospective study conducted at AMRI Hospital, Bhubaneswar from August 2008 to November 2015. Total 614 patients were recruited on the basis of strict inclusion and exclusion criteria. The mean age group was 32 years and mean follow-up was 36 months with minimum follow-up period of 12 months. Patients with unilateral PIVD were included in the study with clinico-radiological correlation in the form of positive SLR test and femoral stress test with corresponding MRI finding. All the patients were advised for a minimum of 6 weeks of conservative therapy before surgery. Similarly, patients with multilevel PIVD and root involvement with Coda Icona syndromes were excluded from the study. Out of all patients, most of the patients were having the pathology at L4, L5 level, followed by L5, S1 level. There were 118 excluded, 456 contained, 4 foraminal and 46 sequestrated disc herniation in the study. Modified McNabb criteria, ODI score and VAS score were used to evaluate at 24 hours, 1 month and 1 year post-op period. All patients were mobilized on the same day except 8 patients because of comorbidity or intraoperative complications and were mobilized on next day. Half of the patients were discharged on the same day and around 44% patients on first post-operative day and 5% on second post-operative day. All the patients were operated with using Destandau's endospine system, which essentially constitute a cannula and a trocar and cannula with working insert. The working insert provides a 4 mm space for 0-degree endoscope, 4 mm suction cannula, 8 mm space for working instruments, and a space for nerve root retractor. All the patients were operated in the knee chest position after administration of the general anesthesia. The localizing device was used to identify and mark the label. 15 to 20 mm skin incision was given, just 5 mm lateral to the midline for introduction of the system directed towards the interlaminar space of the affected site. After exposing the protruder disc, it was punctured and the loose disc fragment were removed. The result was compared with McNabb grading system, and at 1 year follow-up, the successful outcome in the form of excellent and good result was achieved in 96% of the patients. The VAS score decreased to 2 from 7.8 at 1 year of follow-up. The ODI score was also decreased to 14 from 64. In this study, the transient paresthesia was found in 14 patients, transient EHL deficiency in 1 patient, wound dehiscence in 4 patients, nerve root in 2 patients, dural tear in 4 patients, recurrence in 2 patients. In this study, there was no occurrence of neuroworsening. Superficial wound infection was found in 6 patients and spondylodiscitis was found in 4 patients. We all aware that discectomy for PIVD is most commonly performed spinal surgery. The basic principle of all different techniques that present in the literature is to relieve the nerve root compression induced by the herniation. Microdiscectomy is considered as a gold standard for lumbar disc surgery among all minimal invasive surgery with success rate ranging from 88 to 98.5%. And the success rate of this study was 95.9%, which is comparable to the existing literature. The complications reported in large series with patients undergoing microdiscectomy include wound infection, discitis, dural tear, and recurrence, and these figures were also comparable with this study. To conclude, endoscopic lumbar discectomy is a safe and effective procedure to address the lumbar disc herniation. It is now an established method with advantages of minimal skin and soft tissue handling, magnified intraoperative image, cosmetic surgical scar. This technique allows early mobilization and faster recovery. The result of this study, as well as those from the other authors, are very positive and encouraging. In few years, the endoscopic spine approach may become the new gold standard for lumbar disc surgery in properly selected patients. Thank you for your attention.
Yes, very nice. Saurav, just unshare your screen so that we can have a discussion.
Yes, sir.
May I ask Amit Jhala? Amit, are you here?
No, probably he's left.
Okay. Okay. Kartik, any comment on this paper?
Yeah, I think it's a very large series and very well done series. The few things which I would like to think is, find out from the authors yourself, and thing is that one, what was the time duration taken when you started the first cases, and what was the time duration taken for the later cases? Was there a large difference in terms of the learning curve establishment? Two, in terms of choosing the patients, did you selectively choose the L4551 in the beginning, or was there any criteria which you avoided to do that? Main thing is, what is the time duration taken? Because most of the people are doing the micro or the mini open techniques are shying away from endoscopy because they are scared of the time duration taken, and it is demanding. So is there any look into that which you have done?
Yeah. May I take up, Saurav? May I take this question?
Yes, sir. Sure, sir.
Yeah. So initially, when I started this study, it is about in 2008, and we think 20 cases we left for the beginners or the learning curve. After that, we have taken this study. So initially, it took about more than an hour, 1 hour, 1 hour, 30 minutes like this. But in the later on, it's a single level unilateral disc in 25 to 30 minutes. Initially, I took the second half of the questions of your answer is the L4, L5 and L5S1 left side. I start with the left side because left hand is the suction tip and right hand the operating instrument. So I took the left side first. Maybe about 20 to 25 cases. Then we thought about go to the opposite side, sometime the stenosis or bilateral, then the multiple level disc, all these things. And the right side also immediately after 20 to 25 cases. And this go on gradually. I think the time taking and when the anesthetist, your paramedics, and how to do the positioning, all these things, everybody will acquainted the technique. The total time taking will be definitely very, very less, is less than the 20 or 30 minutes total surgery, I mean to say. Anything Rohidas want to add?
I just wanted to comment on this. So many times this question is asked by the patient also and by the surgeon who want to learn MISS. How much time you take for particular surgery? I think that is not required at all. Whether you do a nice surgery, whether you are satisfied after the surgery as a surgeon is very important. Destandau has shared his experience after 16,000 cases that today when he is going to do a surgery, he doesn't know whether he is going to take a long time or whether he is finished in particular time. We are concerned about the better result, better exposure at the time of surgery, not for the time of the surgery which we require. And this principle I have followed since 1993 in open surgery also and MISS also.
Yes.
This comparison in my setup, microsurgery takes 25 minutes and endoscopy takes 45 minutes is useless.
May I add something?
Yeah,
you go ahead.
Probably I learned this in 2004 as a general orthopedic surgeon at the age of about 45. Definitely, it takes a lot of time in the beginning because of a learning curve. I had the fortune to go to Bodo, learn it under Dr. Destandau himself. But as the time passes, once you are used to it, it really takes less time and it is really satisfying for the patient as well as for the surgeon. That's what my opinion.
Yes,
So
Manu.
don't go for the time of the surgery.
Manu, you have to unmute. Manu, you have to unmute. Manu, you have to, yes.
Morning, everybody. Sir,
I got
yes, morning, everyone. Sir, coming back to this, to the paper, very well presented by Dr. Saurav. And I understand it's a very large series. You had almost 650 patients that you had operated. Now, going back into the literature and picking up similar papers, there are not many. And most of them have come from people who have been trained by Dr. Destandau. Now, the thing is, in this paper, after such a extensive series, what would be your comments regarding your first 100 and the next and the last 100 cases? And did you have a subset as a follow-up in this series where you compared about the complication rate? What were the reasons for few things like recurrence and incomplete clearances happening? Is there anything specific that one has to safeguard against the major or the more significant complications in such kind of patients?
Yes, initially when there was the 100 cases, I took, I think, only the 455S1 and L3, L4. Gradually, I took over the L1, L2, and when I was not so much of confident about my technique, I used my Norbrook retractor for about 1 minute or more than 1 minute. And that creates some problem, that weakness, and they develop the paresthesia for about 2 to 3 months. And then it recovered over more than 3 months, it recovered gradually. So that was a learning. And the second one is the dural tear. When I started my surgery, first time, I think about 30th or 31st cases, I pushed my neuropathic cranially. That was pushed so big, about 2 centimeter around. Then I asked my neurosurgeon colleague to take over and open that, and then remove it was almost 1 level above. The surgery was L4, L5. The patty was almost 1 level above that 3, 4. Then the dural tear also occurs once when I was trying to negotiate and remove the patty with my Norbrook or that hook. That hook also creates the dural tear. Initially, I was doing this, putting some muscle patch and then Surgicel, but that was a bigger one. So that needs to close it. I removed the outer tube, inner tube. Through the outer tube, I took the long needle holder and the very small sutures, 20 sutures, and stitched it. There are a lot of things I learned gradually. This presentation, Dr. Saurav, which was a study up to 2015. I think it is another 5 years past now. The recurrences, I think, is minimized very, very less nowadays. Almost within these 5 years, I have not got in a single case of recurrence. The left out, I think we are the visualization field. We are putting the telescope inside the disc space and find out any loose fragments and all. So that's why the recurrence rate is drastically reduced. Any other point?
Yes.
Dr.
Can I have just one quick question?
Yes, Manu. Go ahead.
Sorry. No, I just wanted to inquire, Dr. Saurav, when you had done the functional outcome in these patients, has any electromyographic studies been done for the back muscles, or is there any subjective criteria or parameter whereby you have studied about the posterior spinal musculature, what happens to it post this procedure?
No, sir, everything was by the clinical examination. No subjective parameters was taken on account.
One thing I want to ask.
Yes, Dr. Bhandari.
Dr. Srinivasan, then addition of newer instruments like say 3D camera, then the ultrasonic bone cutter. I think have you encountered that the complication rate, the operative time has drastically reduced? Because when I saw you operating with that 3D, I really felt that it is really much better than using a single. Of course, it is quite.
The question is that I don't bother about the time of the surgery.
Time results wise also.
No, listen. Result also. Every patient is a different thing. It is not an appendix or it is not a cholecystectomy. Every patient, in every patient, you have to decide the approach, how much bone you want to remove, how much disc you want to remove, how much nerve root decompression you want to achieve. And for each and every patient is different.
So the
Okay, we
instrument.
think, Dr. Bhandari, we are having the time now. We have to go to the next topic that will be presented by Dr. Mukul Kaushal. Now I have a pleasure to invite him to present the topic. Mukul, please go ahead.
Make it full screen.
Yes. Unmute Mukul. Unmute yourself.
Okay, sir. Am I audible now, sir?
Yes, audible and visible. Everything is fine. Go ahead.
So the article I've selected for this journal club is published in Indian Journal of Orthopedic Surgery. It's a 2020 issue. And the article was the functional outcomes of Destandau technique for endoscopic discectomy for a symptomatic lumbar disc herniation. The authors were Dr. Mahadev M. Guge and Dr. Sanjeeb Bhandari. I chose this study because it was a recent study with a prospective design and it compares the endospine results with the previous endospine authors. Well, the lumbar disc herniation surgery can either be approached through an open method or an MIS method. The MIS method propagates to address the pathology without producing any iatrogenic excess-related morbidity. In MIS also, we have either a microscopic option and an endoscopic option. The endoscopic option, they're still subdivided into an interlaminar option and a transforaminal option. Well, the authors in this study, they utilized the endospine system, which was pioneered by Dr. Jean Destandau in the early 1990s. And they wanted to evaluate the functional outcome and possible complications of the Destandau technique of endoscopic lumbar discectomy. It was a prospective study from year 2012, which enrolled almost 105 patients with a minimal follow-up of 1 year. And the procedure was performed at 2 different hospitals. The inclusion criteria was a unilateral central or paracentral intracanaliculated disc herniation, which was confirmed by an MRI, lower leg radicular symptoms in the corresponding dermatomal distribution with a failed conservative treatment for at least 6 weeks, positive SLR test, femoral stitch test, and progressive neurodeficit in some patients with a positive clinico-radiological correlation. They excluded patients with any demonstrable instability, lysis, listhesis, any patient with Corda-Equina syndrome, any patient who had a negative clinico-radiological correlation, all extraforaminal disc herniations, and any patient with the previous lumbar spine surgery was excluded. All patients were evaluated with the X-ray dynamic standing lateral flexion extension views of the lumbosacral spine and MRI lumbosacral spine with screening of the whole spine. The Destandau endospine system consists of an outer tube, a trocar, and a working insert. The inner insert has actually 4 ports. The first one is for a 0-degree scope. The second one is for the suction. The third one, which is an 8 mm working port, is for the working instruments, which is placed at a 12-degree angulation. And the fourth port is for the nerve root retractor. That 12-degree angulation helps to keep the tip of the working instrument always under vision while working. The outer tube has ratchets designed to adjust the working depth of the inner insert and helps in adjusting the magnification. The surgical technique, the patient is placed, operated under general anesthesia in a prone position in either a modified knee chest position or as is shown in this picture. And a localization pin is used to mark the level under fluoroscopic guidance. After prepping and draping, a 15 to 18 mm skin incision was placed just lateral to the spinous on the side of the pathology, and the fat and the aponeurosis was incised. Subperiosteal elevation of the muscles was done to expose the interlaminar window and the medial facet, and the endospine tube, outer tube with the trocar was docked in a predetermined sagittal inclination of the disc space. The trocar is removed and the soft tissues inside the outer tube are cleared and the working insert is placed. Then a small laminotomy is performed by resecting the inferior margin of the superior lamina in a cephalad direction and then medial part of the inferior facet laterally using a 45-degree kerison till the superior attachment of the flavum is detached. This was followed by excision of the flavum in a caudal direction using a 90-degree kerison to expose the dural tube and the traversing root under endoscopic vision. For a paracentral disc, the authors the root was gently retracted medially either with the inbuilt nerve root retractor or by using neurosurgical patties. For an auxiliary disc, a patty was used to gently push the root laterally. For contained disc, analotomy was done using a spatula or 11 number knife, and loose disc fragments were retrieved with a disc forceps. And the sequestered discs were gently removed or teasing it out with a nerve hook and then grabbing it with a disc forceps. Once satisfactory root decompression was confirmed by its free movement, hemostasis was achieved with bipolar cautery and small gel foam was placed inside the defect. After removing the tube, the facial aponeural layer was closed and skin was sutured, and a water impermeable dressing was applied. In the post-operative course, the patient was mobilized out of bed the very next day. A neurological and SLR assessment was performed. The patients were discharged within 2 to 5 days, depending upon their pain response, and the follow-up was maintained at 3 weeks, 6 weeks, 3 months, 6 months, and 12 months. And the minimum follow-up was reported at 1 year, and with maximum follow-up of patients up to 7 years. The functional assessment of leg pain was done with the visual analog score. Back pain and activities of daily living were assessed by Oswestry Disability Index. At 1 year follow-up, a retrospective assessment of the clinical efficacy was performed by McNabb's criteria. Radiological assessment was also done with the AP lateral dynamic X-rays at 6 weeks and 1 year to assess instability. And during follow-up, all the complications were recorded and managed accordingly. The statistical analysis was performed by a SPSS version 16 software using repeated measures ANOVA test, and the level of significance was set at p-value less than 0.05. The results, there were 72 males and 33 females out of 105 patients. The average age was 38 years. 76, almost 72% patients were left-sided pathologies and the rest were right-sided. The mean follow-up was 3 years, ranging from 1 to 7 years. The mean duration of surgery was 60 minutes, which ranged from almost 40 to 70 minutes, and the average blood loss was around 50 cc. All the cases have a positive SLR test, 5 cases femoral stretch test positive, ankle jerks was positive in 27, sensory deficit was involved in 58 patients. 7 patients had motor involvement, with the 5 patients having a grade 3 EHL, 1 patient having a grade 4 S1, and 1 patient having a grade 4 quadriceps strength. Majority, almost 95% levels were L4-5 and L5-S1, and less than up to 5% patients levels were L3, L4, and L2, L3. These were the results. The VAS score improved significantly statistically from 8.37 to 0.82 at 1 year follow-up. The ODS score also showed an improvement from almost 65 to around 5. The McNabb score also improved, and almost around 88% patients had an excellent to good result. And among the 7 patients with motor involvement, all except the one with a grade 4 ankle regained their original power over 9 to 12 months. And 88% patients were able to join their sedentary work duties within 3 weeks post endoscopy. And heavy manual labor and sporting activities were allowed after 6 weeks of endoscopy. The complications experienced by the authors were they experienced dural tears in 4 cases. All occurred in an auxiliary disc case, and they were managed with watertight closure, and there was no evidence of any dural leak in the post-operative period. 2 patients developed discitis, which manifested as a sudden onset back pain within 1 to 2 weeks post the initial recovery. The diagnosis was made on clinical grounds, and they were managed with strict bed rest, IV antibiotics for 3 weeks, followed by oral for next 3 weeks, and all responded and healed by good radiological fusion at the end of 1 year. 4 patients had recurrence, and 2 were early recurrences within 3 months, which was confirmed with a contrast MRI and managed with a revision Destandau endoscopy technique. Superficial wound infection occurred in 1 patient, which was managed with dressing and antibiotics and healed within a week. 8 patients experienced a transient neuralgia, and which improved over the next 3 to 6 weeks. Coming on to the discussion, Mixter and Barr in 1934, they first reported that classical laminectomy and discectomy as an operative technique in the management of prolapsed intervertebral disc. In retrospective analysis of long-term outcomes of standard discectomy for lumbar disc herniation, Yerimitsu et al. Found that 76% of these patients had some residual back pain, which was severe in almost 12.7% of cases. And hence, there was a need of introduction of microscopic disc surgery by Casper and Ayer Sargil, which added the refinements in approach enabling minimal anatomical damage. And endoscopic discectomies reported good results between 80 to 100%. And a prospective randomized controlled trial comparing full endoscopic interlaminar as well as transforaminal lumbar discectomy versus conventional microsurgical techniques by Rutten et al. Reported equal clinical results of full endoscopic techniques and the microsurgical techniques. This study also reported significantly reduced postoperative pain and work disability in the full endoscopic group and increased rate of non-serious complications in the microscopic group. And Sir Jean Destandau from France in the early 1993 developed a posterior interlaminar endoscopic discectomy technique with unique instruments for the surgical management of this lumbar disc herniation. And in study comparison head-to-head with other endospine studies, According to the MEC criteria, the authors of this study had almost 88% excellent to good results and almost 11.42% fair outcomes. No poor results. The results are comparable with studies presented by Destandau et al. And Patton et al., which showed almost a 90.5% and an 80.95 excellent results respectively. Kaushal et al. With a series of 300 cases had 90% excellent to good results, 8% fair results, and 2% poor results. Dey et al. With a series of 614 patients presented excellent results in almost excellent results in 78% cases and good results in 17.9% cases. The VAS score for leg in the present study was significantly improved from the preoperative average of 8.3 to 0.8 at final 1 year follow-up. Dey had also reported a similar improvement. Dey et al. Has also improved similar improvement in VAS score from 7.8 to 2 in a year. In the present study, the ODI score was reduced significantly from 69.65 to 4.51. Dey et al. Also reported improvement in ODI scores from 64 to 14. The complication rate experienced by the authors in the present study was 18%, and in a series in comparison, in a series of 199 patients, Destandau et al. Reported 0.69% incidence of dural tear. Incidence of dural tear reported by Kaushal et al., Dey et al., Patton et al. Was 5%, 0.6%, and 4.76% respectively. And recurrence rate in the present study was higher than the recurrence rate found in studies conducted by Dr. Destandau et al., Dr. Dey et al., but was lower than that found in Kaushal et al. The incidence of discitis was noted in every series, but in the present series, it was 1.9%, while Destandau et al., Kaushal et al., Patton et al. Found 0.5%, 5%, 4.5% incidence respectively. So in the present study, 88% patients were able to resume sedentary work and between 2 to 3 weeks of surgery with restrictions to avoid heavy manual work for minimum 6 weeks. And Walter et al. Following discectomy reported that 40% of their patients were able to return to work within 5 weeks, while Casper reported mean return to work time of 18.6 weeks. So
Mukul,
it was faster return to work.
Mukul, it is time to conclude.
Okay, sir. So the shortcoming which I felt was that this study had a short-term follow-up and the comparison of lumbar disc herniation with microscope and other endoscopic based technique was missing. In conclusion, the authors concluded that Destandau endoscopic lumbar discectomy provides good illumination, excellent visualization, and magnification for the surgeon through a smaller incision, all of which help to minimize procedure-related morbidity and prevent serious complications. The short operative time and the hospital stay, decreased need of analgesics, and early return to work make the procedure quite cost-effective. The only downside is the steep learning curve to improve triangulation, depth perception, and hand-eye coordination. Thank you.
Yeah, Mukul, just unshare your screen. It is a very nice and elaborated description. I think you have very precisely concluded the topic. Dr. Bhandari is here. Can I ask Dr. Bhandari one question from my side? It's a technical points. For the dural tear, that is written that watertight muscle and watertight closure. What is that you mean?
Watertight closure means the muscles usually we may not close that much, but in those cases where we found small dural tears, most of these cases were really done in civil hospital or general hospital, government general hospital at a tier 2 city and in our own hospital. And fortunately, with just closing the muscles properly, we go through the separating the muscles to one side. We just close them tightly, and fortunately, we did not have any dural leak in the post-operative period.
Nice. Amit, are you any comment on this?
It's a very nice paper, nicely followed up, good follow-up of 7 years. And I think most of the things have been discussed in previous paper also. The only thing is that this is a very good technique. One of the techniques out of so many which are available. And it has stood the test of time. So nothing more to say.
Yeah, one thing I want to say is that this was done by a general orthopedic team, not as a spine surgeon's team. So it can be done by a general surgeon team and at a government hospital. Both these points, so people
very
should
nice, very
apprehension about this technique.
And you have the set of the instrument in government hospital also?
No, I used to carry my own instruments.
Okay, okay.
So the very good point about this, there is no microscope which is required. That is one thing. It can be portable so that it can be carried everywhere where you want.
Yeah.
And the third, the system is not that costly like other endoscopic systems. So
that's the main thing which I want to say.
So it is one of the good techniques for the beginners or who have a cost constraint and want to do a minimally invasive with an endoscopy. So that's a good technique.
Manu, you unmute yourself. You want to add something? Yes, unmute yourself.
No, I do not wish to add, but I have two questions which I wish to ask. One is to Dr. Bhandari. So the first question is that all the studies that you compared your Destandau technique in your patients, almost 100 patients, 105 patients, where you compared to other studies, all the studies have shown an excellent result in roughly around 80 to 90% patients. Dr. Jean Destandau had the maximum number of satisfied patients. Now the thing is, if you look at it from the other side, the unsatisfactory patient, almost a rate of 5 to 8% of those patients who are not satisfied with the procedure. Can you shed a light on what was the cause? What was that subset of patients? Is there anything that a surgeon should be aware of when picking up patients? And my second question is to the seniors here. If one has to do a study, a prospective study, what should be the design of that study to be able to understand exactly how efficient this Destandau system is in a particular set of patients? So these two questions. One is for the general.
I think Dr. Bhandari, we have a very good discussion after onwards this way, and Rohidas is going to speak on this this topic. So you can conclude within a one sentence, Dr. Bhandari. Please answer him.
Yeah, only one sentence. That probably the earlier learning curve, either some dural TS and some neuralgia, and secondly, the discitis problem in two patients where the patient suffered a lot for about 2 to 3 months. These were the patients who were not happy. That's otherwise, no permanent damage has been seen, and of course, recurrence in a few cases.
So all the points we will take up gradually, Manu. I think we will discuss gradually. Now, as time is not permitting us, we have to go shifting to the case presentation. The Kartik, are you here now? Are you ready with your presentation? I think Kartik is not here. Can I invite Ayush Sharma? Dr. Ayush Sharma, are you ready with your presentation?
Yeah, I'm ready.
Yeah, please go ahead.
So I'll share my screen.
Yes.
Yeah, I think I am visible.
Yeah, you are visible, you are loud and clear. Go ahead.
So I'll straight away go ahead to my case. So this was a 65-year female. She was a known case of carcinoma rectum and presented to us with back pain for 1 month. There was no history of trauma. She is in severe pain, so much so that she's on morphine 10 milligram 4 times a day. Her ODI is 45. She is even unable to walk or stand. Neurologically, she is absolutely intact. Reflexes are normal. As you can see in the picture, because she is a known case of carcinoma rectum, there is an anterior resection of rectum and a colostomy bag was put in January 2020. So this was her original adenocarcinoma report, which histopathology report, which concluded adenocarcinoma of rectum. This is the X-ray she presented to us with. As you can appreciate, something happening at L2 and maybe even at L1, and definitely there is some amount of kyphosis with some lysis happening here. So naturally, we also did the basic parameter, her blood parameter, ESR was 50, CRP was slightly raised. C is HB7. Remember, this is the 3 months back at the peak of lockdown, and her blood group was O negative. And in Bombay also, we could not find a blood group O negative at that time. And these are her MRI. As you can appreciate, there are signal changes at L1 and L2, and definitely some destruction of L1 happening here. These are the axial cuts, and of course, he is neurologically intact because the posterior elements are completely spared, and it is only the anterior part of the body which is getting involved. This is the CT again showing extensive destruction, so much so that there is a 38.6 degree angulation which is happening between the superior and the destroyed inferior end plates. So we also investigated it thoroughly, considering the history she presented with. There was no M band. We got a PET, and PET suggested that the only active lesion was L1 or L2. we always get a screening in this case just to rule out anything else. And to our surprise, we get a space occupying lesion at D8. And you can see this is what's presented with here at L1, and there's a space occupying lesion at D8. Of course, neurologically it is intact, and we didn't find any sign and symptom of this lesion, but this was incidental finding which we got. And you can see the axials here. Now, interestingly, we got a case report also when we went through the literature that it could be a metastasis from esophageal adenocarcinoma, which has been reported. If we, so that was one more information. We look at the instability score and it is 13, so we knew that something has to be done. We went ahead with a biopsy because any such case, you do need to confirm the diagnosis before intervention. And to our surprise, we can take a frank pus from the lesion at L2. And this comes out to be staph aureus MRSA, which is sensitive to a few of the drugs, including vancomycin and a couple of others. The cytology report says no malignancy. Now we come to this, what to do. She is a 60 years old lady, medically not very fit. And this was at the peak of the lockdown. Do we conserve her? Do we operate the lumbar spine? Or do we go and do the thoracic as well? Should we operate both? So this is the case. And sorry. So any comments from the panelist? Hello. Hello. Am I audible? Hello.
So,
so any comments from
Dr. Ayush? Just now, in your opinion, where do you feel that the primary pathology, if at all you're going to be operating in such a patient? Now, pain is the paramount symptom here, and the patient has come to you for relief of pain. What do you think is the basic cause of pain in this patient there?
So what we felt is that the destruction, the pain is coming from the infection, and not only pain. If you look at the X-ray which we showed, she is definitely significantly kyphotic. So something has to be done here at this level. And we felt the finding is just a incidental finding. That was our call. But there is extensive destruction happening here. But she is a very, very sick patient. So we have to take it into account.
You have a sick patient, you have an immunocompromised patient, you have a patient with clear-cut infection, which is the root cause of pain, and it's a neurologically stable patient.
Yeah.
So I don't think your lesion at D8 is going to be an absolute emergency as of now.
Okay. Yeah.
It is something that has to be tackled. Now, in a patient, you have to decide as per your operative time and pre-operative assessment, what is going to be the stability of this patient under anesthesia if you take up a surgical procedure. I mean, Dr. Jhala would like to comment on this.
Yeah, Jhala sir, any comments?
I think, as Dr. Monu said, that the patient has got a severe back pain. That's the main complaint. So the thoracic lesion does not look to be the main to be tackled at present. So they have to tide over the situation of back pain first. You've also got the pus which is there. I would like to know what was it? What was the infection? It was staph, right?
Yes, it was staph.
So it was staph. So what my contention would be to start with the antibiotics at present.
Okay.
And just wait and watch for the response of the antibiotics, because you see there are two vertebrae which are involved. If you go for the intervention, it would require a longer intervention in the COVID time. So I would just like to go over the crisis by just giving it IV antibiotics, because now we know what the lesion is. So I would just stop and give the antibiotics, see for the ESR, CRP and the counts which are, and regularly follow up the patient. And of course at a bed rest at this point of time, because there's already infection usually has a newborn formation. So it can stabilize by itself, because there's a lot of newborn formation in pyogenic infection. And they're healed by a bony ankylosis rather than a fibrous ankylosis, what we have. So looking at this situation overall, I'll just wait and watch with the antibiotic, that That would be my, and if it doesn't improve, then we might think for the interventions. That's what.
So exactly that was our thought. We put the patient on antibiotic, but she was bedridden from before only, and she had a small bed sore. Within 4 weeks, she started developing a big bed sore, and her general condition was not good. So we thought we should do something, but to do an entire job would have been very, very difficult. So our plan was to do a stage surgery. First, do just to stabilize her from posterior so that we can mobilize her, and maybe if needed go second stage anterior. So this is what we did. We fixed her percutaneously, 2 above and 2 below, and what we did is we used this vertebroplasty cannula, and like a transpedicular bone grafting, we used the autograft and allograft and mixed it with vancomycin. So this is the kyphoplasty cannulas we could put through the transpedicular and fill the aspirated and curated the body as much as we can, and fill everything with the bone graft. As you can see here, this is after the aspiration and curated of the body, which is the defect. And this is what we could push the autograft and allograft. We could mobilize her within few days and see at least the bed sore and everything got over. And this is what we had post-operatively. You can see how we have filled the whole thing. Fortunately for us, and the plan was to do maybe if needed a second stage anterior. Fortunately for us, this is the follow-up. This is the pre-op. This is 6 weeks under antibiotic. Now we have 3 months follow-up, and she has been holding well. So till now, even the bone you can see is decent, not that great, and unfortunately she has a recurrence now. But she is able to mobilize. She is able to stand, and they are treating her for the recurrence which has happened. We went through the literature, and even this is the paper which says that what to do in such cases in surgical treatment of pyogenic spondylitis using. So they say that single stage posterior may be sufficient in patient with relatively minor bone destruction. And in cases where extensive bone destruction in such cases, the other recommendation is you do a posterior, stabilize the patient, and once the patient condition improves, maybe do a limited anterior. So that was the case, like something like a damage control orthopedics MIS would be your rescue in such cases. Our anesthesia team did agree to give her, considering we said we won't do anything extensive. So that was the case.
Okay, thank you, Ayush. Can you unshare your screen?
Yeah, sure. Thank you so much.
Any comment from the Dr. Bhandari on this case? Any comment you like to have, or any? Kartik, are you here?
Yeah, I want to add something, sir.
Yeah, go ahead, Srinivas.
As Ayush doctor presenting, so this
Kartik,
showed
Kartik, you share your screen now. Kartik,
yeah.
you share your screen now.
The culture showed,
Srinivas, go ahead.
Culture showed Staphylococcus aureus. So definitely it is a pyogenic thing. So I think personally my view is to put implants and the major surgery in such a comorbid associated patient who is immunocompromised also. So definitely it is going to be a major perioperative risk for the patient. So I agree with Dr. Monu and Dr. Bhandari as they told. So initially put them on a good culture sensitive antibiotics and wait for a period, so that once they settle down, I think you could have taken for major fixation and implant.
After 4 weeks of antibiotic cover, that's what I told. After 4 weeks of antibiotic cover, that is the time we took her when she started developing bed sores and everything. So
yeah,
she was on antibiotic as per the culture for 4 weeks, and then even the blood parameters are pretty okay. But we thought if we leave her with, she will be bedridden forever, and things will go downhill, especially if that's what is our experience in such cases.
Could you have avoided the vertebra which is infected and not put screws in that?
We always feel that if you put that index vertebra, it gives you better controlling kyphosis.
Yeah, but when there's a pyogenic infection, probably I will not even put.
It's like after 4 weeks of antibiotic, we thought still the posterior elements were pretty good and they didn't show any involvement. we thought if you put even the screw in that index vertebra, it does give you better control, because usually we had a big void, and if it fails like anything. That's what that was the reason for going in that short screws in that index vertebra as well.
In traumatic situation, we do put screws in the hole and we do get good hold. But in infected and that to pyogenic, I was a bit skeptical about it. That's all.
But till now, he has followed about 3 months. I think patient is doing well and is able to stand up by herself. I think very difficult case, very challenging case. He has taken very aggressively after 4 weeks of antibiotic, and he did his job. Now patient is improving. So all well. Thank you, Ayush. Now I invite Kartik to present his case.
Thank you, Dr. PC. And I'm just presenting this case for reason of different reason. This is a 48-year-old male who had a fall from a tree a year ago, who was treated conservatively elsewhere, and then reported back to us about 1 year later with severe mid and low back pain, difficulty in doing normal activities, which is progressively worsening pain with normal neurology. So this was the presenting picture which we had, the X-rays, which showed a fractured L2 with the MRI. My apologies on not having a complete set of X-ray, MRI and scans, as it was stuck with my associates, both of them who are down with COVID. And this is what I have. So this is what we see. So what are the options available at this point of time? Can I ask anybody?
Yes, I think Arvind Malhotra is here.
Yes, sir. Yeah, I am there.
Yes.
So in these cases, it's got a lot of compression at L2, and the fracture is there. So we generally, in these delayed cases, we would like to do a posterior spondylectomy laterally and with fixation 2 above and 2 below. So that's what we usually plan in delayed cases. Fresh, we could have tried to say that the fracture might have opened up, but in this case, as it is totally pressing, so you would need to excise the bilaterally. Transpedicular.
So how comfortable, how easy is it to do spondylectomy at L2 level?
So I think it's quite easy at lumbar level compared to, because the only issue is the nerve root. I know, but we actually do it with a microscope, and we are able to do actually. Initially, we were doing anterior first and then posterior, but lately, more or less we have. Hello, yeah. You can hear me.
Yes, yes.
Yeah.
Go ahead.
So last almost 10 cases now we have done. If you had asked me about a year back, I would have just done, anterior corpectomy and plus posterior fixation. But nowadays, all posterior is possible. So it is a bit tricky when there are 2 nerve roots involved. So we try that even unilateral, we are able to decompress, if possible.
Okay. Yeah. Any other comment, Dr. Bhandari? Unmute yourself. Unmute.
Not much, really.
Okay. Go ahead, Kartik.
So we had the options: posterior, anterior, global, MIS posterior, MIS anterior, combined. Okay. Now, any of these options are acceptable and we can be doing it. Now, what was done was this, which is a little, I just wanted to show this because we've been dealing with the MIS and with various jigs and various contraptions. And we thought we could show something which can be done without any of these contraptions. Standard anterior approach was used, patient in the right lateral position, and through a small 5 centimeter incision like a mini open, what we do for the olives, etc. We approach this patient the same way. You could use these kind of jigs, which Amit and others, and also we have done quite a few with the olives. So this But then we decided that this is not available in most places and is not commonly used by everybody. So therefore, let's use something which is done and repeatable by everybody. Through a 5 centimeter incision retroperitoneal approach, we just used regular Hohmann retractors. Place the Hohmann retractor posteriorly at the pedicle and the foramen junction, and then used a deaver as well as a small retractor, and we could go ahead and do a complete corpectomy as well as a cage fixation. The idea was this, that this is a repeatable procedure done in any government hospital or any institute, and we do not need specialized retractors or specialized jigs. The same 5 centimeter incision which people talk about, we do the same thing. And my emphasis on this is that most of the times we are stuck with companies not having retractors, not giving retractors to people. And therefore, how do we modify it? And my take on this was that we'll go ahead and show that this can be done with just 2 instruments or 2 retractors around, which is easy to be done and quite comfortable to be done. So some suggestions on this was that, for the juniors who are doing it, do quite a bit of open anteriors before venturing into minimally invasive. I have the luxury of working in an institute where I have the vascular or the CTVS or general surgery colleagues the next theater and available whenever I want them. So in the private setup, when you're doing it, make sure that you take the support of a vascular or an access surgeon. Few cadaveric cases before doing one in the OR. It's very important to be familiar. And it's important for the juniors to think conversion to open is not a failure. There's no room for bravery or bravado in this. Lastly, minimally invasive spine surgery is very doable. It's what is going to be exciting. It produces excellent outcomes, less blood loss, decreased hospital stay, and less morbidity. And we can do all this with minimal inventory or gadgets required. Thank you.
Yes, nice. So very small incision, and you have done the pathology, tackled the pathology very nicely. It's a very good presentation, Kartik. I think we need a comment from the Amit.
I think it's very nicely done, but if you see the anterior approach, the evolution of the anterior approach or Rolif, it has come exactly in the same way. And the first paper, if you go through of the Michael Mayer, he did an open, MIS open anterior. That means he did not have a spatial retractors. He just put the pins in the upper vertebra, pin in the lower vertebra, and the retractor which was there for the psoas, which he used to retract the psoas. And then the recent retractors are built over the same technique what Dr. Kailash has presented. So definitely it's doable. There is no point, but one has, because in this time, I think everyone has stopped doing anterior. In previous set, everyone was doing anterior, so it was easier done. But for the newer surgeons, if they want to take this, they have to be well versed with the anterior techniques first in a full open manner, and then do minimally invasive anterior. So that's what my take is for this case. It's very good technique. It was how it started the MIS anterior by Professor Mayer.
Kailash, could you just unshare your screen? Any other comment from the panel? Otherwise, we will go to the next talk. That will be start with Dr. Srinivasan. I'd like to invite Dr. Srinivasan to start with the discussion about the Destandau technique and his take. Ruidas, you will share your screen and unmute yourself. Yeah, go ahead.
No, basically we are talking about Destandau's technique, and we want to focus on the beginners. There are so many techniques which are available, so many approaches which are available, and the youngster has to choose between so many techniques which are available in the market. We'll try to discuss this topic on these points: skin incision, MISS, whether local anesthesia or general anesthesia, cost of the instruments of various techniques, endoscope size, endoscopic exposure at the site of the pathology, wet or dry, pure or true endoscopic versus endoscopic assisted, versatility of the particular technique, learning curve, complications and modification of the technique which is necessary in future. First, we'll start with the skin incision. The youngster has to decide or study whether the size of the incision in millimeters does it matter with the outcome. Mohinder? Mohinder?
I think Mohinder is not here. Manu, can you go ahead on this question? Can you take? Unmute yourself, Manu. Are you here?
Could we have it again? Yes.
Yeah.
Dr. Veda, sir.
Yeah, you just tell us that when you
start. We want to discuss for the youngster, a young surgeon who wants to start MISS has to know these basic things.
We just let me speak a few words, then you start with the Manu. Manu, just hold on one second. When you start this surgery, Manu, that when you took up this endoscopic technique, Destandau technique you are doing, I know that everybody kept in mind that how to deal with the pathology. Never thought of the skin incision, how millimeter 16 or 18 or 10 or 8. Sometime in UB, we are doing the 2 ports, maybe 6-1 for the arthroscope or 30 degree or 0 degree telescope. Then for the instrumentation is 8 millimeter. So there will be 2 port, one is 6 millimeter, another is 8 millimeter. Sometimes the people are doing only 8 millimeter or 10 millimeter incisions. So considering all the things, you just have a Manu, go ahead.
Yeah, see, my take on this is very simple, sir. There's a saying that one should not lose the sight of the woods for the vision of the tree. So, just for the sake of having a small incision, but one does not have to jeopardize the procedure. Incision is not the paramount thing over here. The pathology is how we tackle that pathology, how we are able to do justice to the patient, that is important. The skin incision can vary. It can be 1.5 centimeters, it can be 2.5 centimeters, it does not matter. Even now, after so many years of doing this, skin incision does not matter.
Kartik, you want to add something? Kartik Kailash, please. Kartik, you want to add something?
I want to add one thing.
Yeah, go ahead.
Yeah, it is sometimes the ego of the surgeon that I have done to 12 millimeter or what he says, if you take small and struggle a lot, it is not good at all. The size of incision definitely does not, you have minimal access. In the sense the access related morbidity should be less. When you are require 18 or 20, sometimes in obese patient you may require 22 also. But it does not matter. What matters is that you should be comfortable and your ego should not come in your way of really tackling the pathology.
Correct, absolutely.
When we are tackling the pathology, we are taking out the risk. There is a reasonable amount of tissue that has to be handled. It cannot be less, it cannot be more. Now, to be able to do justice to that pathology, it is within the ambit of competence and within the ambit of instrumentation that you are justified to have a limited amount of incision. You cannot go overboard, and you can certainly not compromise upon your incision size to gain access to the basic region. There has to be a balance.
Yeah, Dr. Mohinder, can you any your comment on this, Mohinder?
Yeah, I think small incision, cosmetic incision is even a patient's requirement also. If you see how microscope came into being from open spine surgery, that was, I think it is a quote of Dr. Srinivasan only, that there were bar girls who were very much impressed with big scars, incision on their spine. So microscope brought in the small incision and endoscope further brought in the small incision. So I think from patient angle, patient does feel that if small incision will be there or not, to understand it is a small incision. I mean, we are not talking about that. But as far as from patient perspective, incision is important. And I am sharing with you the professional commitment of bar girls when how the microscope came into being to make the incision small. I mean, this is what I am sharing from literature. Otherwise, it is a 10 millimeter, 15 millimeter, 18 doesn't make much difference.
Correct.
The thing is that we started with minimally invasive spine surgery, MISS. But if you think now it is a maximally invasive at the site of the pathology.
Yes.
We are not compromising on
I
the
think
goal.
that is what I agree with Dr. Rohidas.
The
That
incision in millimeter doesn't matter.
Incision, if you say small incision, local anesthesia, but inside you've done an inadequate work, I think that is not justified. Small incision should also be achieving the same surgical objective what we have been achieving with open spine surgery. I think inside work remains the same what we have doing by open spine surgery. So endoscopy has surely minimized the access related morbidity. That is to be understood.
Okay, I think we'll go
Now
ahead.
we'll go to the second point.
Yes.
When
Can I add one thing?
Yes, Amit, please go ahead.
See,
Yes.
for the beginners who are taking this, see, incision doesn't matter, but the surgery and the main aim of minimally invasive is not the skin incision.
Yes.
The muscle damage, and I think that is very, very important to stress rather than skin incision. So because of this thing, muscle damage is less. Even the microscopic technique came by Casper was because of the muscle damage, which was less. It was not the skin incision that you have to make it small. That is one point. So that's very, very important. And you should have an adequate incision. I would not say that there is incision doesn't matter. It does matter, but you should have an adequate incision. You should not have a 5 centimeter incision and work to protect that. So you should have an adequate incision for which a beginner who wants to take is comfortable. So they may take a little bit bigger incision initially and then come down. So these are the 2 points which I.
Yeah, absolutely well taken, Amit. This is very, very important. Muscle and the periosteal stripping, then the vascularity to the muscles and how much retraction, all these things counts. Okay, go ahead, Srinivasan.
The second issue is the MISS techniques under local anesthesia or GA. It is very lucrative for the patient also. Patient wants to have the surgery under local. That is, some patients prefer for that. But the surgeon has to really think about it, whether the local analgesia role. It is.
Yeah, Mohinder is doing all these things, I think, by spinal nowadays. 80 to 90 cases, 80 to 90% by the spinal anesthesia. And some people are transforaminal people, they are doing the local under local anesthesia. And the Amit, your comment on this?
You see, again, the same thing, whether you do a GA or a spinal, according to me, it does not matter much, because whether you do in spinal or GA, except patient is much more comfortable for me in general anesthesia rather in spinal anesthesia. For a beginner who wants to take it, they should not do it in spinal anesthesia because they are going to take a lot of time. Right? So if you are exceeding that time, then to add on to the anesthesia in spinal, it will become spinal with add-on of GA, which is much detrimental compared to GA alone. Having said this, there are certain advantages in certain patients of local anesthesia procedures. Like if the patient is not fit for GA, then if you can do the same procedure in a local anesthesia and get the patient the same result, it may be a beneficial. So either GA or a local, whenever it is required, that's what my take would be.
I think in these days of COVID, probably it will make a bit different, because general anesthesia even for the anesthetist, they feel that it is a bit risky. So if you can do, otherwise it does not make any difference.
Arvind Malhotra, are you here?
My take is, if it's under local, the muscle relaxation is not at all good. For in cases of spinal canal stenosis where you want to go on the opposite side. And the GA gives you very nice muscle relaxation. And if your anesthetist is good, you can finish the same surgery within the time log of the surgery done with the local anesthesia.
On this point, that muscle relaxation, Mohinder, you want to add something, because you are doing most of the cases now under spinal anesthesia.
I think I have experience of using a tube, Destandau tube, or now I use miniature Destandau tube. I call it arthrospine under local, general, and spinal. So I fully agree with Dr. Amit that a beginner, at least if you have done 500, 1000 cases under GA, then you should switch over to maybe local or spinal for that matter. And even I have seen local, most of my colleagues who are transforaminal proponents, I have seen experts when they are doing this procedure, the patient is not comfortable. Still patient is wincing with the pain after local. So I have seen patient comfort is more under spinal. And as far as muscle relaxation is concerned, I think once the tube is in, that relaxation is, to me, it has got, it's immaterial. And in fact, like under local, you always ask for you do a test, you ask the patient to cough, and at times there is a small fragment in the disc space which comes out. So in my setup, since we are doing spinal anesthesia from last 5-6 years now, my 90% of canal decompressions and discectomies are now under spinal. Unless there are contraindication to spinal, then we switch over to GA or maybe local. I mean, local rarely we use. And what I want to share with you is that I do tell the patient at the end of the procedure, try to cough forcefully so that I can see under spinal I am sharing with you. And patient is somehow participating in the surgery. I am talking to him. He is watching his procedure on the monitor. I tell him, this is your nerve root, this is your disc which I have moved, your nerve root is now free. So that is another advantage of spinal. And I mean, patients are quite comfortable under spinal. And for if you finish the procedure in 1 hour or 1.5 hours. And most of my patients, I think now close to 1000 plus under spinal. All patients are pretty happy, and my anesthetist is also comfortable, happy. So no issues.
So during the surgery, you are showing the total surgery to the patient also.
Yeah. He is conscious, watching on the monitor, and he is talking to me. And
one thing just I like to ask you, when there is a patient is a very muscular man or a very bulky man, even if the tube are inside, are you feeling comfortable by mobilizing the tube during mobilization of the tube?
No, nothing. I mean, I don't feel whether muscles, in fact, under spinal, muscle relaxation is there. Local story is different. In spinal, muscle relaxation.
That point I want to like to you. Next, Rohidas, go ahead.
Can I just ask Mohinder one question?
Yes, Kartik, please go ahead.
What position do you put the patient in on? Do you use a knee chest position? Because putting a patient on knee chest position for under spinal.
No. Kailash, I use only bolsters, and patient is pretty comfortable. I don't use knee chest position.
Kartik, you wanted to say something? Your question was interrupted, I think. Which point you want to learn? Or you just want to know?
Sorry?
The positioning, about the positioning.
Yes, he explained that. He said that. Yes.
Okay, nice. Now, Rohidas, go ahead.
Third thing, the beginner has to know about the cost of the instruments. Now, in Destandau, there are no special instruments. We use the routine instruments. In the paper explanation, they have mentioned about this outer tube, inner tube, the Kerrison punches. All the rest instruments are the routine instruments. If you make if the incision is small, if you want to use a smaller sheath and other things, the instruments become delicate. And the delicate instruments, there are more chances of breakage and the recurrent cost of the system, and which is by
the smaller incision. Yes, smaller incision, delicate instrument. There are the number of instrument for the transforaminal, for the interlaminar, and then for the disc is separate instrument, for the stenosis for the separate instrument. I think Amit can comment on this. Amit, are you here?
Yes. Yeah. I just missed the question. Can you just let me know what
about the instrumentation? Instrumentation, the cost of the instrumentation, the versatility, and then the breakage and the recurrent cost of the instrumentation. One instrument can be used for different procedures, or separate instrument for the transforaminal, interlaminar, and for the disc and the stenosis. All these things. Yes.
I'll tell you, if you are doing whatever technique that you are doing, you pursue that technique. Because for every newer technique, you will have a different set of instruments. And unless you have a different set of proper instruments, you will not be able to do that particular procedure. So for the beginners, I would ask them to go for different, the training for different systems. And then whatever they are able to manage, they should go according to that. Because if I do a transforaminal, I will have the whole set of scope and burr and the instruments which are different. Destandau, the total instruments are different. Of course, the least instruments which are there is in Destandau, and microtubular, then you will have again the whole set of instruments which are there. So I think
yes,
it's
I mean,
very,
the question is the recurrent cost of the instruments.
the recurrent cost of the instruments, I think it is in Destandau as well as in microtubular. They are the routine instruments that you can use. I don't think there is a recurrent cost. It is only the setup which is costing, like tube for the microtubular and Destandau for the Destandau. Otherwise, you can use your routine instruments in both the setups.
No, when the instruments are delicate, there are chances of breakage.
So that is there in transforaminal. So transforaminal, definitely there is a recurrent problem because the instruments are slender.
Every system where there are delicate instruments. Yeah.
Yes.
PC, I want to add one thing.
Yes, go ahead.
Exactly the slide which Dr. Rohidas has shown in 2004. I attended that workshop and there were two techniques which were shown by Dr. Rohidas, this Destandau technique, and Dr. Gore, the transforaminal technique. And I went for Destandau technique. The first reason was the cheap, the cost effectiveness. It was about 10 times more costly for the transforaminal and the setup required. So I went for the Destandau for that only because of the reason of cost effectiveness. And I have
well taken. Yes. Your point is well taken. Yes. Yes, Amit also clarified that point. Yes.
Not only cost effective, you only buy Destandau, you can do transforaminic, you can do canal decompression, you can do disc. Whereas if you have a transforaminic, now they push you, transforaminic guys have no interlaminar system also. So see the cost, how much cost goes skyrocketing. And you see, they say, iske liye transforaminic karo, canal decompression karna to ye system kharido. It means you are you have to spend 50 lakh rupees. And how many of them will be able to learn this technique? Only it's a big question mark. I mean, now the things, endoscopy is an established field, but I think when the market stands behind any technique, then things become market driven. So I think Destandau is the by far time tested highest number of series done by master and other surgeons. And it is most cost effective, and most of the things you can do in your theater. You don't have to, and in fact, good thing is same camera, even 30-degree scope can be used. I mean, if
now we are coming to Mohinder. Your point is well taken. Now we are coming to your next point, that is endoscope.
The thing is that
size, degree, and the mobility. Yes.
Surgeon has to decide how much he want to spend on that particular setup. He has to decide about the recurrent cost of the instruments, how he is going to bear that. That is the important thing. The fourth thing is the endoscope size. Size, degree, and mobility. In Destandau, we use 4 mm diameter endoscope, which is 0 degree, 18 centimeter, like a routine endoscope. When the endoscope becomes angulated, we have to pass the instruments with that parallel to that endoscope. Now, when the endoscope size becomes smaller, the vision also becomes smaller, and the depth appreciation with that 2D is a little bit cumbersome. So that is the thing surgeon has to with himself about the vision at least in the initial stages. This is the mobility with the endospine. You can move around everywhere. When you target through a small incision, the mobility at the site of the pathology, initially it was not good, but nowadays with that small thing also, they are able to move the system at the site of the pathology. Any comment on this?
Yes, because of this mobility, this Destandau technique, sometimes L4, L5 and L5S1 due to this anatomical orientation, both the level of lumbar canal stenosis may be L4, L5 and L5 level, or the disc surgery, we can do from the single port just by tilting the same side and opposite side and also one level below, like L4, L5 and L5S1. This is the beauty of the instrument. Any comment? Amit, you want to add something?
Yeah, I'll just add one thing. That you see, if you want to do an endoscope, and if somebody wants to go for an endoscopy, because now I am doing both. I am doing an interlaminar endoscopy also, and I am doing microtubular also, because this is my transition.
Okay.
So if you want to do a posterior or you want to do transforaminal, that's a different thing. But if you are choosing your posterior technique as your main principle, and then if you are already doing if you want to go for an endoscope, I think there is an advantage for the beginner. not for anybody who is already doing that technique. If somebody wants to start again, then interlaminar endoscopy is also 4 millimeter. You can have all the instruments which are now with the newer sets of endoscope which are available for interlaminar. You can use your routine instruments there also. You can decrease the site. You can have the same amount of mobility what you're talking in the Destandau, and you have the burr and everything which is also available. So if for the beginner, if they want to learn an principle wise interlaminar, then I would ask them to go for and learn from beginning the interlaminar endoscopy. Right? Those who are going, those who are there for Destandau and they want to continue, that's fine. But this is what my take is.
No, the basic issue is that now everybody wants to use a 4 millimeter or near to 4 millimeter diameter endoscope for better vision. Is that correct?
So 4 millimeter is a standard even for interlaminar pure endoscopy.
Yes. That is what I'm talking about. Yeah.
So that full endoscopic what we were using before, I think it was 2.7 millimeter. I think we are now, they are also shifting to the 4 millimeter nowadays.
The stenoscope which are available for posterior interlaminar.
We'll come to that point afterwards.
Yes,
sure.
Yes. So that is the point. That is the take. Okay.
Now the exposure at the site of the pathology. Because we are maximally invasive at the site of the pathology. We don't want to compromise at the site of the pathology, or we don't want to compromise the goal. When we have a smaller incision, everything comes to an incision in millimeters. When we have smaller incision, we use smaller endoscope and there is a limited exposure. Now with stenoscopes and other things, they have a wider sheath, wider endoscope. So everything comes to the exposure at the site of the pathology in interlaminar. Previously, if the exposure is adequate, then tackling of the pathology is better. That was in open surgery also. If you expose more, if you know more the anatomy, you will be able to tackle it. So this thing is important in cases of cervical stenosis, the canal stenosis or cervical, where you want to expose it adequately to tackle the pathology. Any comment?
Exposure at the side of the pathology.
Yeah.
Dr. Rajamani, are you here? Dr. Rajamani, are you here? Please unmute. Please unmute. Please unmute. Monu, you can go ahead. Monu, please go ahead.
What I feel is, as a person who has who's the latest entrant into this technique, what I feel is he's spot on. Dr. Srinivasan is spot on. First of all, what is important is visualization. You have to have a wide visualization and you need to see the boundaries correctly without distortion, and you should be able to observe them minutely, not just what is there in the center, but what is there in the periphery, what is there in the nooks and the corners. So I feel with the mobility of the system that we are using, the Destandau, it scores a point over above other systems on that aspect.
It should not be indirect. You should not assume that you have to compress the nerve root. You should be able to see the nerve root completely. You should be able to mobilize the nerve root. It should not be indirect. It should be a direct appreciation of the thing.
Yeah, I want to add one thing. Here we have multiple settings where you can take it up and have a wider view, and again you can go down and have a really magnified view. So that is the advantage of distant endoscope, what I feel.
Yeah, there's a zooming effect also. You can go inside and outside. That if you go inside, that the visualization field will be little less, but the visualization magnification will be far better. And if you go just little above the Srinivasan, you want to add something?
Yes, sir. Many times more than the disc, sometimes we see the facet joints causing the nerve compression, ligamentum flame causing the compression, and additionally disc causing the compression. So all pathologies can be visualized well when we have enough exposure of the surrounding tissues, as Srinivasan sir was telling. So the entire pathology can be viewed only through this Destandau system, I feel.
Correct. Absolutely. So, Srinivasan, I think it is already well taken. Now, next we can go ahead.
Next issue is wet or dry technique. Now, there is a differentiation. Two groups are there. Whether it is a dry technique or air technique or a wet or saline technique. Now, wet means you use saline. Now, in the techniques where you want to use saline, there are some these things. They want to use saline to create a pressure for hemostasis, and this helps them for the muscle retraction and creation of this cavity. But there are limitations. When there is a dural tear, there are limitations to convert it into open, and they have to treat that. But with the dry, we don't have to convert it into open. Through the same incision, we'll be able to tackle that dural tear or something like that. But in dry, what happens, because there is nothing which is helping us to minimize the muscle which is intruding into the tube, we have to nicely separate that muscle. In wet, the saline pressure takes care of that muscle coming into the operating field. So these are the basic things. In wet, saline is a necessity. In dry, we have that air which gives us the cavity which we are using for the MISS.
What about visualization in the dry? Visualization in the dry and wet?
No, I also believe that this saline in wet technology give us some sort of a 3D feel also. I don't know. Mohinder will be able to talk on
Mukul, are you here? Mukul?
Yes, sir.
Yes. Any comment for this? What I am asking about this, Rohidas is telling about the complication and the when there will be dural tear, you have to open it. But in the same incision, we can hope the Destandau technique. The second point we have discussed about this visualization and clarity of picture in the wet and the dry. Any comment from your side?
Sir, the appearance of the anatomical structure, it changes quite a lot in dry and wet system. Even though with wet we can go further down, the risk of swelling reduces, but we have to appreciate that the dural structures and the ligamentum flavum, they appear quite different in a dry medium and quite different in a wet medium.
Yes, yes.
That is what I feel, sir.
Oh, may I come in?
Your experience about the dural tear?
Sir, most of the dural tears, actually, when we are working quite close, we shift to smaller Carrison punches. So, in essence, if we cause a dural tear, most of the time they are so small that we just put a gel foam or a muscle patch, and we generally don't repair them, sir.
No, it's a thing for beginner. Initial stages, initial 10 or 15 cases, you tend to have these complications.
What is the relation of the
whether it is easy to manage with wet or dry?
Any complication, fluid related complications?
Yeah, I think we were with Dr. Son, and he shared one of the serious complications of one of neurosurgeon colleagues, where the patient ended up with a blindness. Number one. Number two is, now I am coming to since I am a user of Destandau technique, and I have innovated now miniature Destandau, which is a dual system where you can switch over to saline when you are close to dura. So now the question is why I have to think of this. My main concern was when I was using Destandau system or dry system, arthrospine system, there is always a swelling of the scope when you are very close to dura. So to address that problem, I went into this, and this is an open system. There is no rise of pressure around the dura. But when UV is being used or other systems are being used where there is a pressure created inside the canal, and if this pressure goes beyond critical limits, it has serious complications. Patient, even when you're using doing a transbrahmanic or for that matter interlaminar, if surgery is prolonged, patients if they are under G8, it could be very dangerous. If under local or spinal, patient starts complaining of neck pain or a headache. So this is very, very important to understand. The fluid complications are very, very serious at times. And one of the patients, I think, probably had a blindness of the eyes when she was doing.
That is a very dreaded complications. Very dreaded complications.
So it has to be an open system. I mean, in spine, it can't be a closed system. And pressure has to be a certain level. Beyond that, if pressure goes above 25 to 30 mm of mercury, it will have serious fluid
Yeah, that is the key point, I think. That is the key point. You
my
have to
friend,
maintain...
Dr. Lokhande, he had complications. He was using saline in cervical spine. He had some emphysema, fluid going into the lungs. Then one complication where the fluid went into the peritoneum. So retroperitoneal fluid complications are very, very serious. So surgeon has to be very well versed and with these complications. And this cannot be a closed system. Otherwise, complications are very, very serious and dangerous.
Yes, yes. So I think your all the points are well taken. I think you have to, the most important point is that you have to maintain the fluid pressure. It should be less than maybe 30 or 40.
Yeah. It should be only gravity aided, no use of pump or nothing.
Yes, yes. So, okay, Rohidas, you go ahead because we have now sort of time. Please go fast.
The seventh point, the next point is true pure endoscopic or endoscopic assisted. The youngster has to decide what he want to pursue. I have not seen any evidence for this terminology, whether it is pure when the endoscope and the instruments go parallel, it is pure, and when the endoscope and the instruments go with an angle, it is not pure or it is endoscopic assisted. The basic thing is when we started with laparoscopy, we never termed it as a endoscope assisted laparoscopy. It was laparoscopy and the endoscope was known as laparoscope. So same thing is accountable here. For the endoscopic assisted, we get a wider exposure and mobility.
Yes.
The eighth point, the next point is versatility of the technique. With Destandau, we can target each and everything. Lumbar disc, lumbar canal stenosis, multiple level stenosis, posterior cervical, anterior cervical, thoracic disc with stenosis, intradural tumors. And the same set, we can use it for the instrumentation also.
Now I think on this point, I will have some little presentation. Can you unshare your screen?
Stop sharing my screen.
Yeah. My screen is visible? Yes. Okay, so this is a patient of 52 years lady. After 4-5 fixation, she landed with the another complication that is called that adjacent level disc herniation, that was L5S1, and there's a huge disc, and this is the discectomy we did from the right approach. This is L5S1 right approach. My right hand, this is the cranial end, this is the midline, and this is the caudal end, and this is the facet or the lateral aspect. So this is the superior lamina. We have detached the ligamentum flavum, and this is the hypertrophic facet. And after removing the hypertrophic facet and the thickened ligamentum flavum, because the patient was 52 years, there is a huge axillary disc. And this is the nerve root and this is the dura. In between, there is a huge axillary disc. It was a little bit adherent and is a really bigger size. We used to this regular instrument like 3 mm Carrison punch and 3 mm disc forceps. There is no special instrumentation for the Destandau technique. And after removal of the disc, there was a contained area. Also, there was a small fragment and irrigation with the normal saline. This takes about hardly 20-25 minutes surgery, and the clear visualization is very good. And so we have discussed about the journey and the learning curve that Amit was telling, that you have to see the variety of the surgery. Maybe there are 4 endoscopic techniques at present we are practicing in the across the globe. That is UBE, Destandau, and the full endoscopic, and the 4th one is the transforaminal. So you have to think all the 4, and then you decide, you stick in mentally, you prepare that this technique I can take up, and you stick to one technique. As Amit was telling, it is very, very important. From beginning, you have to decide that this technique I can do and go ahead. So another patient is the LCS with the disc, L4, L5, which is middle-aged person, 4-5 level, disc with the hernia stenosis. And this is the technique we use, the Destandau technique again. It is the same side, this is a left approach. So this is my nerve root and this is the dura. This is nerve retractor and giving the space a little bit more in the lateral aspect. So the lateral, this is the disc. This is the discectomy with the same Carrison punch. And then we are going to the opposite side, protected by the patty, neuropathy. And this is the ligamentum flavum of the midline, just below the spinous process. And we are going to the opposite side by undercutting the ligamentum flavum. Undercutting the ligamentum flavum, and then the decompression of the opposite nerve root. This is the opposite side nerve root. This is the opposite side nerve root, and this is the dura. It's completely decompressed. Even sometimes you can have the discectomy of the opposite side. Just this is the beauty of the mobility of the instrument. You can tilt and mobile the opposite side, put a petty cranial cordon, and the disc also can be removed from the opposite side. This is the opposite side disc. So this is the opposite side nerve root, and this is the same side or left side nerve root. So you have to properly decide first which technique you want to learn and go to the master. Take the proper training from the master, and then you start your technique or surgery. This is the very, very important for the learning point of view. Third case is the 62 years lady undergone open laminectomy and the nerve root decompression of L4, L5 and L5S1, that is lumbar canal stenosis in 2012. And then there was a lot of problem with the patient with the crippling pain, and then a lot of people are advised for instrumentation, stabilization, and then the epidural nerve block, and then refer to the psychiatrist. And finally landed with the Bhubaneswar in 2016. There was a wide laminectomy done at L4, L5 and L5S1. We did the contrast MRI to confirm the disc, and it was the herniated disc, again recurrence disc at L4, L5 in the right side. And this is the most important point, is to make a cleavage between the fibrous tissue and the bone. We are just cutting a little bit of the bone at the medial aspect of the facet so that the fibrous tissue can be detached. Once you got the cleavage, that 50% work done, and then you retract with the nerve retractor medially, and the lateral aspect you can push your nerve, that same 3 mm Carrison punch disc forceps to remove the disc. So proper training after the proper, first you have to decide that which technique you want to learn. Second is the proper training from the master. And third point, what are the things you are doing and complications you are facing. You compile everything, present in front of your colleague and the senior or teacher or masters. Or you have the course that like 2010 we have in Bhubaneswar. That Destandau, I presented my paper, all the complication, and he was solving the problem in front of everybody, and then the comments from the other people. Now another patient is extraforaminal disc. This MRI and X-ray seems to be nothing to be much problem, but in the axial view, it is a huge extraforaminal disc at L4, L5 right side, L4, L5 right side. So this is the not the regular interlaminar approach. It is a approach from the foramen or extraforamen. This is the isthmus, and this lateral aspect of the inferior articular facet. And this is the regular. We are marking giving the localization, but you have to go a little bit above. That is 5 to 10 millimeter on the foramen. This is the regular marking the interlaminar space, but this is the foraminal approach, little above 5 to 10 millimeter, and then target to the isthmus or target to the lateral aspect of the inferior articular process of the facet. So this is the foraminal disc. Just approach from the posterior aspect, not interlaminar, but directly the extraforaminal area, and this is your disc. So the versatility of the instrument, you can approach to the foraminal disc also very easily and comfortably, and remove the disc. And takes about the same amount of the time, not if you are doing regularly. And this is your end of the surgery with nerve root. This is the nerve root, and this is the disc. So this is the final that everybody used, all these spinal surgeons, they used to face regularly the dural tear. How to, this is a herniation of the nerve root. Try to push the nerve root with the muscle patch, because it is a very small tear. We used to face very small tear with the 2 to 3 millimeter only. So muscle patch helps to push the nerve root, that herniated part, into the sac, and then seal with the surgical. Thank you. Now I will unshare my screen. Okay, now Mohinder, are you ready with your presentation?
I think we have some slides from S.Rohidas sir also.
Yes.
So that I'll continue afterwards.
Okay.
Mohinder? Okay. Mohinder is not here, I think. Hello? Okay, then Srinivasan, you go ahead because Mohinder is not here.
Can I ask
Yes,
one
yes.
question for
Kailash, go ahead. Go ahead. Yes.
Now that Destandau and UBE seems to be the current favorite baby now, as far as publicity is concerned.
Yes.
In terms of versatility, in terms of the things, could you give us the beginners on the advantages of Destandau as compared to the UBE, or whatever is the risk factors involved?
We have already discussed a lot of advantages of the Destandau. Now let me speak on the advantages of the UBE. UBE is a technique that we are doing the surgery with both the hand, like the arthroscope. Left hand is the telescope and right hand the operating instrument. It needs two ports. That is, one is the 6 millimeter and another is 8 to 10 millimeter. The advantages of the technique that you can use the 0 degree and 30 degree both the telescope. Like if you are an arthroscopic surgeon or the orthopedic surgeon, you can use the same instrumentation. And the spine instrumentation is open surgery, the same open surgery instrumentation. The second advantage is that you can go to the disc space and decompress the disc space, and also you can put the cage on through the same technique. And also you can ask your for the Hassan another step go ahead for the fixation technique.
रोहिदास अपना म्यूट करो जरा, बहुत डिस्टर्बेंस आ रहा है। आपका डॉगी भौंक रहा है।
नहीं भैया, मैं ओपीडी में हूँ।
तो ये कौन का आवाज कहाँ से इतना ज्यादा?
Somebody has to mute. I think Dr. Rajamani and Dr. Rajamani, are you? Yes.
Yeah.
Good morning, sir.
Sorry. Good morning. I was a bit late for personal reasons.
Yes.
Yeah.
Presently, can you unmute yourself because there are a lot of sound is coming.
Mine?
Yeah, I think so. There is no. Yes. Thank you very much. So I think there are a lot of advantages. We have discussed about the Destandau. Now the advantages, first thing is the two technique and the same arthroscopic technique. If you are operating arthroscopic surgeon, this is very good. And also go to the opposite side. If it is a foraminal disc, also it is very good. And also you can go to the disc space and put the cage. There are a lot of advantages. The side effect also we have discussed recently that just 2 minutes before about the fluid problem. There are the blindness, there are the cervical problem, that the fluid goes to the chest, fluid goes to the peritoneum. So you have to be a bit cautious about it. And once you learn the technique, I think is very good. We are there with the Dr. Son in the South Korea. He is regularly operating with the same technique that EBE. But you have to be cautious. I think Destandau is a little bit risk-free and it is more risk, according to me.
Thank you.
Okay.
Doctor.
Yeah, Srinivasan, you go ahead.
Kartik.
Yeah.
One thing the young surgeon has to realize that UBE is only one hand technique. Your one hand is used to hold the scope. You are using the endoscope with your left hand. Your right hand is only working hand. So that the learning curve is more steep in UBE as compared to the Destandau, because here you have to keep the tip of the endoscope exactly in front of your instrument and then move around.
Yes.
Second thing is, if a surgeon is right-handed, now Dr. Swan does all the techniques all the pathologies from the left side. When you want to approach from the right side, the endoscopes come to your right hand, and you want to use the drill and the other instruments with the left hand, which is a little bit cumbersome for the right-handed person. So all these basic the realities of the technique, the surgeon has to understand before going into that. We are not blaming any technique. We are just trying to enumerate the advantages, disadvantages, realities of each and every technique. Okay?
Yeah, well taken. Go ahead with us now.
Yeah, I think just one point. I mean, Dr. Srinivasan has very rightly pointed out that the learning curve is a bit longer in UB. So I also faced same problem. In fact, Dr. Mukul, when he came back from Korea, and we being arthroscopic surgeons, so we devised a technique or a method where you can shorten your learning curve. So I think that probably Dr. Mukul can share later. Now Dr. Srinivasan can carry on with his talk.
Now then, this is the thing which I just wanted to share. Yeah, the Destandau, we can use it for each and every pathology. This is anterior cervical. We are going anterior cervical. This is the vertebral artery. This is the suction, and the foraminectomy is something around. This is around 8 millimeter. This is around 10 millimeter. Now this is the extruded fragment of the disc. Yes. So this is a disc preserving surgery. You get a very nice vision, mobility also. You can angulate according to the direction of the disc space. Now this is the disc in the anterior cervical. Now this is intradural tumor also. This is a neurofibroma. You can use micro scissors. And the thing is same incision, no drain, no catheter. We have mobilized this patient after 2 hours, discharged the next day. And this is the dural closure with anasto clips. So the Destandau thing is the versatile technique. You can use it for each and every pathology, except the intramedullary tumor. This is watertight closure.
Anasto clips.
Yes. Easy and fast.
Yeah.
Mohinder, be ready with your presentation.
Okay.
We have very less time to left. I think we have to.
How much time for presentation?
2 minutes.
I think I should be done.
Yes.
2 minutes and 30 seconds video.
Yes.
Okay.
Now we'll talk about the learning curve with the Destandau and the complication avoidance. Let Mohinder share this thing.
Yeah.
No, complications I think PC will be covering.
Okay, it's okay.
This is okay. Already I have discussed that. I have shown that dural tear, and the rest of the thing we can discuss.
Now
and unshare your screen now.
We have to discuss about the learning curve.
Yeah, learning curve also
avoidance and the modifications.
Okay. आप अपना share screen हटाओगे तब मेरा होगा कैसे होगा?
Yes, now you share your screen.
ओहो यार ये share screen हाँ. Okay. Yeah, I think MISSAB tutorials. So first I will briefly share about this presentation. It's opening up. Yeah, just give me some time. Yeah, there you are. Okay, so what I think what I was asked to highlight was key. So Dr. Rohidas, you wanted me to talk about endoscopic MI fusion also. One slide.
Rohidas is not there.
Okay, so my reason of doing endoscopic MIS fusion is that first goal is to achieve a adequate neural decompression, and then you should have a advantages of minimal invasiveness also. So these goals are achieved by spine endoscopy also nowadays. And why I switch over to fluid when I am very close to dura, I get a very clear operating field. One of the problems which I was facing with the Destandau with my arthrospine dry system, that whenever you are close to dura, there is a repeated swelling of the scope. I mean, most of my colleagues must also have experienced that, and direct decompression is possible. And endoscopically also you can achieve a good fusion. Now this is the instrumentation. Now this is I call it as a second generation arthrospine DEW system, where surgeon has luxury of using it in dry mode also. in a saline mode also, you can see in saline mode, there is a working insert is changed. There are only 2 ports now. Through one side, fluid goes in and it comes out through other side. And you can see this is specially designed scope by me. Arthroscope has a 2 ports. Here it is only a single port. So fluid goes in from here. It created a hydrostatic pressure about 25 to 30 millimeter around the dura and comes out from here. And this is a working insert which is used for dry scopy. And when you have to use a dry scopy, you have to use a suction also. In dry scopy, the principles remain the same as Destandau technique. And when you are using a saline, you follow the principles of PSLD. So this is to be understood. And this is a miniature Destandau system. I'm a little, you can say like we change car models, mobile models. So this is a little more miniature system. And this is just to share with you the patient with spinal instability and a lumbar canal stenosis. The first step is level marking. Then about when I am planning a fusion, then I keep incision about 15 to 20 millimeter, but standard canal decompression and disc surgery, it is around 10 millimeter only. Then same dilator and then sliding of the tube. Then this is how first step is to have an adequate neural decompression. That is the first prerequisite. Second is you can see how I have nicely exposed the disc here. And now next step is to prepare a disc bed, put in the graft. And this is now I have changed over to saline mode. Now in my view, I feel the advantage of UB is through a single port, I am able to achieve disc surgery. I am able to do neural decompression, discectomy, canal decompression. But when I do MIS fusion, then I create an additional port. Like in shoulder surgery or in knee arthroscopy, we create additional ports like when we are planning a PCL, especially for my orthopedic surgeon. So here I create an additional port like UB, the way Dr. Sohn does it. Now I am preparing a disc bed under fluid scopy. And this is you can see how beautifully scope goes in virtually. It is sitting over the end plate now. And you can see the inside view of the disc under fluid endoscopy. And this is a 10 size sizer going inside to decide which size of cage you have to put in. And then these are the intraoperative steps. I usually for low grade slips, I usually go in for a monolateral fixation only. And this is a patient with 9 months post-op follow-up doing extremely well. And this is another patient. And I will not go much into details. Yeah, that's it. And now I think I have to
just hold on, Mohinder.
I have to
going to the next. Yeah, just hold on. I like to clarify. This was the 11th point, Dr. Rohidas. The 11th point is what is the benefit of the modification that you have already shown here in your talks. That the benefit of the modification. I like to have the comment from Amit. Amit Jhala, are you here?
Yeah, I am there.
Yeah,
so I think it's a very good modification because you need a dry and wet endoscopy. And if you can do both the things, the biggest advantage of the wet endoscopy is saline, and it gives the best feel for vision. So I think it's a very good modification by Dr. Mohinder, where you can have an endoscope, you can have all the alternatives or modularity that you want as a surgeon when you are doing the case. I think
and third advantage is, Dr. Amit, that you can switch over to UB also, which is now picking up. Create an additional port and put in the scope through that side, and you start working UB also.
Yes.
This is how I have made things more simple and economical for my colleagues.
That's perfect. Very nice.
So, do I need to show now spine cervical?
No, I think we need to move fast because we are only 10:25.
Yeah.
And we need to close it.
Go ahead, Mohinder.
So I quickly show the video. So this is again a same miniature Destandau tube you can call, or arthrospine tube, where I have done a good decompression of the cervical cord. And you can see I do a spinoplasty. You can see release of spinous process. Then I go to contralateral side and then work. So this is what is a small video which I have shared with you. So I have preserved the spinous. Now this is a video which is showing the endoscopic laminotomy. I think I need not show this. And this is finally, I have switched over to fluid in the cervical spine. If you see, I'm using a RF to control the bleeding, and down below cord is nicely decompressed. So in the end, switching over to saline endoscopy gives you a more clear view, and you can see inside more in a more better way. So I think I
yes
stop my speech here now.
Yeah. Now, I think there are only one point left, that is a complication and how to avoid the complication, how to control the if there is any complication. I like to have the comment from the Dr. Rajamani, please. You just share your experience about the complication and how you are dealing with the complication in the endoscopic surgery. Rajamani, Dr. Rajamani, you unmute yourself. Unmute.
Good morning to all. I'm sorry I was a little bit late for social reasons. But anyway, answer to the point raised straight away, the commonest complications in any invasive surgery is, am I audible?
Yes, clear.
Yeah. The commonest complications is one that is wrong level surgeries. Majority of the times, always double check. While you do, there is going to this space, there is one way of confirming that is twice and twice and do it.
This is not that clear.
Pardon?
Your voice is not that clear.
Am I audible? Clear now?
Yeah. Just it is not clear, but it is audible. Yes.
For the beginners, the commonest complication is a wrong level surgery.
Yeah, wrong level. You are talking about the wrong level. Yes.
Wrong level. So to avoid that, better always confirm that this prior to your incision, and then once again into the laminar window, and then once again into this space to confirm with C-arm and go with that. And the commonest problem in any case. And next is once again the retraction of the nerve root. People see beginners. This is for beginners I'm talking of. Usually people, as and when they go into this space, interlaminar window, they try to search the disc. And in order to do that, they either retract the root very well and producing a problem for neuropracture later, or have a dural tear. And this thing to be avoided because you go to the lateral border. This is for beginners once again. Face the lateral border first of the dural tube and then search for the dural. So this thing you can avoid a dural injury.
Yeah, your points is well taken, Dr. Rajamani. Very important point. The 2 points you have told, that is the first one is the wrong level. I think Dr. Srinivas, you are doing a lot of cases nowadays. Just unmute yourself, Dr. Srinivas.
Yes.
Any take on this wrong level?
Yes, sir. As Rajamani sir was telling, before starting we have a nice marker to see in the C-arm designed by Destandau himself. So that is very useful. So once you start putting the incision going inside, and after putting the tube inside, I check once again. And while finishing doing a discectomy, again I check. So at least 3 times I check the level. So till now I have not encountered the wrong level surgery. It is a truly important complication, as Rajamani sir was telling.
One more thing also he told, that is about nerve root injury. Dr. Kartik, Kailash, any take on this? How to avoid the nerve root injury during this surgery?
Well, I mean, the only thing is lateralization is more important. So once you lateralize yourself, you could avoid it. The nerve root injury can be avoided by lateralization, most importantly. Other than that, a lot of times you find that you land directly in the axilla with the interlaminar approaches, and that itself can lead to a stretch as well as to a nerve root injury or to a dural injury. These things can be avoided by lateralization and by lateral positioning. That is what I think.
Sometimes we have to sacrifice a little bit more bone on the medial aspect of the facet, so that we can have the lateral recess exposure wide. And also by the pushing the nerve root little bit medially by the neuropathy, then you will get the lateral space more wider, and also the working space will be more wider. Any comment on this, Dr. Bhandari, or your experience about the complications? What are the more complications you have faced during your surgery?
Basic durability, as you said, you should previously we were using this nerve root retractor, inbuilt nerve root retractor to push the nerve root medially. Probably sometimes it used. Nowadays, as you said, neurosurgical.
Yeah, nowadays we are avoiding the putting the nerve root retractor. Any other complication you have faced during your surgery? What the dural tear you told, that how to, we have already discussed about the tight compartment closure and all these things.
And as Dr. Srinivasan said, we also check in between. Once we put the spatula inside, we just check level so that you should not go wrong, because here there is chance that you may go wrong if you don't check.
If you are any doubt, it takes hardly 2 minutes or 1 minute if you want to check it. Definitely always. First, most of the surgeon, I think, so that quite senior surgeon or experienced surgeon like the Mohinder, I think he is not checking regularly. Very rarely, only 5-10%. I am correct, Dr. Mohinder? Please unmute. Please unmute. Yes.
Our wrong level.
Yeah.
No.
Are you checking with all the cases during the surgery?
100%. The instructions to my sister in charge is she will not allow me, once I have checked the level, I have put in the tube, we take a shoot again. I have burnt my fingers once or twice, but last 5-6 years this has never happened. The instructions are, even if I am proceeding with the cutting of lamina, always she tells me ki, we should take a shoot. And it has once or twice it has happened that I was saved from on a wrong level in spite of my expertise of 15 years or so.
How
in
you are
spine
dealing with
endoscopy.
this complication?
So
like
always I put in a tube, take shoot again. I mean, I am at peace of mind. Otherwise, it is very, very difficult to convince a patient, post of round day 1 that aapne wrong level kar diya. And it can have, if some cranky patient is there, it can have a medical legal issues also.
Anytime, have you faced any problem like hematoma compressing the problem at post-operatively patient having the neural problem?
I think in 18 years, never hematoma has never, as a complication I have encountered in my series.
Arvind, Arvind, are you here? Amit, are you here?
Hello?
Yes.
Arvind, please, go ahead.
Yes.
Arvind,
So,
about the hematoma.
so in young, about the hematoma, I don't think, I also have never had this hematoma press on the nerve root having post-op, never. Even if the patient is sometimes on aspirin or, anticoagulants, aspirin, it is fine, but, even with aspirin, we are doing after 5 days, and no, I don't think I think it involves just, you have to be careful in coagulating. We do have to make an effort to have a clean field post-op. I never had this.
Okay. Amit, about the discitis, I just like to have some point from you. About the discitis, we are facing, though compared to the open surgery, it is very, very less, but we are facing. And most of the time, I think Dr. Bhandari also mentioned in his paper that is mostly it is in the first or second week in between after the surgery. Patient complains of the pain and pain. There are no fever, no other complications. If you go for the blood test, maybe some parameters, ESR or C-reactive protein, DC, TLC may be high, but no other complication except, no other manifestation except the pain and severe pain. Sometimes the born not able to move the on the bed also. Have you faced this type of problem, Amit?
Yeah. Everyone who is doing surgery has faced a discitis. There is no doubt about it. And the most important point is a pain-free interval of few days to a week from the surgery to the increase in the back pain that the patient was having. The pain is gradually increasing after that. So, and there is a very important pain-free interval. That means if you say the next day the patient is walking, patient is fine, and after 3 or 4 days the patient will start telling that I am getting more, or because the infection starts about 24 to 48 hours after the surgery. So that's a very important take, that you should have a pain-free interval, and the pain has to be even at rest, even in turning in bed, and corroborated by the laboratory findings. I think that's very important.
It's quite painful for the patient as well as for the surgeon.
Yeah.
Because it takes a lot of time, nearly 1.5, 2 months to really settle, and you have to face the patient, and that is the worst complication which I have faced.
Right.
So only antibiotic is the solution, or any other else, anything else?
For me, I was, you see, there are literature and our experience also, that if the patient and the surgeon have a patience, then this can be solved without non-surgically. But the problem is the patient's pain is so much. The surgeon has no patience to wait, and then you reoperate, and then the patient becomes much better. So our strategy goes down that now if the patient has got a lot of pain, we discuss and counsel with the patient. If they have patience, then we wait. If the patient has no patience, then we just go ahead, debride it, and the patient will be fine. That's what.
One thing I want to ask, whether this debridement can be done again endoscopically?
Yes, For me, once there is an infection, it is not only a debridement, it is a formal fusion, which can be done by MISSAB. But it's a fusion.
Second thing which I want to ask, it is usually aseptic discitis. Once in a long back, we had opened the discitis and we didn't find anything at all. And even the culture sensitivity report was negative. So whether it is really a septic discitis or aseptic discitis, probably the avian of the end plates and something like that.
What we're talking about is the septic discitis. And to get a culture, every time the laboratory does not give the same culture because you've already covered them with the antibiotics. So sometimes these antibiotics, because you have given, you will not get the same culture reports. So then we consider that it is an aseptic one, right? But it may be a misnomer.
If it is a septic one and you want to maintain with the conservative and patient agreed to and well cooperative, then how many days or how many weeks you want to give the antibiotic?
I would minimum give for 2 weeks IV antibiotics, check serially with the CRP and ESR. If they in serial CRP and ESR, they are coming down, then I may stop the IV and go to the oral. If they are not coming down, then I will still continue the antibiotic for further 1 week, right? Yeah. And if even after 2 or 3 weeks, the pain does not come down, then definitely surgery, there's no doubt.
Sorry, Kartik, you want to add something? Kartik.
Yeah, see, our...
Go
ahead, Dr. Bhandari. Please go ahead. You go ahead.
The pain really takes about 1.5 to 2 months to go down. And really, as I said, it is really painful for the patient and the surgeon. How to explain to the patient. So this is the worst complication.
Yes, very painful, very painful. Kartik, you go ahead.
Yeah, our experience, Amit, has been a little bit different with about 12 or 13 of the cases with the discitis where we have done transforaminal endoscopic debridement, lavage, and washouts. And we find that the patients have had good results with the transforaminal endoscopic lavages following this. And I think it's a very useful procedure because it's done under local anesthesia and we're able to get a good clearance. And we don't have to go necessarily do a fusion. So we have about 12 or 13 of these patients now who are done. And the results have been quite good. As far as the antibiotic usage, our protocol is almost similar to Amit, where we do 2 weeks of IV antibiotics followed by 4 weeks of oral antibiotics. So 6 weeks is definitely needed. And only at the end of the 4th or 6th week, the patient is still struggling, then we think in terms of going for a definitive fusion. So far we have been able to avoid about 12, 13 patients.
One question.
Can I ask one question to Dr. Kartik?
Sure.
Yes.
Have you followed up these 12 or 13 patients for more than 6 months or 9 months? Because ultimately when you do a debridement and fusion, debridement and in infection, the end stage is always a fusion.
Correct.
Whether you fuse it formally or you don't fuse it formally, ultimately it is going to be a fusion.
Yeah, we have 1 year follow-up.
One question to Amit.
Sorry?
Amit, one question to you. Just I want to add to my knowledge. Like in a discitis patient, if you have fused, how is the pain relief post-op?
Immediately, patients are very much comfortable.
Okay, that's the advantage of fusion. The pain goes down.
You stabilize them and they are fine. As I think what Ayush showed, the patient pain went away just by stabilization. The antibiotic is going to work later on.
It's like an IM nail for an infective non-infective.
Have you noticed after instrumentation whether this has infected again?
Never, never. Because what we are doing is for whenever the end plates are damaged, there's a lot of vascularity which is there which comes inside. And usually it is end plate infections, not the bone infected. It's the disc and the end plates which are infected. Right? Not like the pyogenic spondylodiscitis where bone is also infected. What we are talking is the disc which is infected.
Rohidas, to answer your question, there has been a study from CMC Vellore, and our experience is with 2 or 3 cases were fungal infections. When fungal infections were there, they had repeat infections because they were inadequately treated with the antimycotics. And that is the only instance. With septic, there's no evidence of that. CMC has got a very nice publication.
And if you have a fungal infection, the antibiotic protocol is quite different. You have to give for 6 months of antifungal antibiotics. Otherwise, it's going to recur. Okay.
Yeah,
long period.
Dr. Kartik's experience of just doing transforaminal debridement and Amit's experience of doing fusion. Is there really difference whether fusion is required? Because Kartik sir also said that
No. I think you lost the Bhandari. You lost the last point with Amit's mention, which I entirely agree.
Yes.
1 year down the road, they all fuse.
The natural fusion. Fusion.
But you get good relief immediately after deployment also.
Correct.
Yeah, that's what I want to stress.
Yeah.
The advantage of endoscopy is you can get a good culture.
Yeah.
Yes.
You can get a good.
So I think I will ask Dr. Rohidas to conclude.
So this was a nice thing for the youngster to discuss about various things, basically about the Destandau and compare about the other available techniques, and they can study themselves, and then they can choose whatever system they want to use for the minimally invasive spine surgery. But basic is minimally invasive spine surgery is not minimally, it is maximally invasive at the site of the pathology. That they have to understand. Okay.
So I think, thank you very much, friends. Today we have overshot a little bit, and I will ask my chairman of the day, Dr. Amit Jhala, to conclude the day.
Thank you, Dr. PC, for nicely moderating the whole session. And thank you all the panelists, Dr. Rohidas, Dr. Mohinder Kaushal, and everyone I'm not naming for a very good session. And it was a very good session for the beginners, not only for the Destandau, but even how to go forward if they want to go for a minimally invasive spine surgery technique. Also, would like to thank our Journal Club presenters and Ayush and Dr. Kartik, along with all the MISSAB faculty who are here. And thank you, everyone. We will meet next month, probably on the second Sunday of November, which comes to at 8th, with the same set of a Journal Club and good topic. We will just find out which good topic it is, and a case presentation. I thank you, everyone, and do connect with MISSAB. If anybody wants to become the member, go to the website missi.co.in and register yourself and become a member of this Minimally Invasive Spine Surgeons Association of Bharath. Thank you, everyone, once again. Bye-bye, everyone.
Thank you. See you. Bye-bye.
Take care, all of you. Stay safe. Bye-bye.
Thank you, PC.
Yes,
it was nice.
Thank you, sir.
Thank you, PC. I was
thank you, sir.
For a social problem. I was late. I'm sorry.
You came late. Yes.
Yeah, I'm very sorry. Thank you.
Thank you, PC, sir.
After a long time.
Yes.
Yeah.
Chalo, Amit. Bye-bye. See you.
Bye.
Bye-bye.
And I want to congratulate PC, sir, for the nice publication in Asian Spine Journal. Yes, many of our Destandau work is not much published, but I think recently we have a lot of publications coming up. And really I'm happy.
Dr. Bhandari also presented, published this year only.
I also
Bhandari sir also got, in Indian Journal. That is also
lockdown, we had a lot of time.
It has really,
we took that.
Congratulations to you also, sir. Yeah.
That presentation also sent by Dr. Rohidas to me. That papers, Dr. Bhandari paper sent to me by Dr. Rohidas, and I asked to Mukul to present that.
Thank you very much, PC, for that.
Yeah, thank you, sir.
Thank you.
Okay, see you all. Bye. Srinivas, bye. See you, Bhandari, sir.
Bye.